Well, complications are always interesting. So I was also going to first of all talk on a rotating toric ICL, but I changed my topic. I'm going to show a cataract extraction following ICL and a removal of an phakic IOL. Ready? What do I do here? Okay.
Video, sir?
No. Yes. Okay. It's not happening. VL6, right? Okay, so this is about now 10 or 12-year-old video. These were the days when we actually did not have a centra flow. And so this is a normal IOL and this is explantation of an IOL. This patient was a second eye and the patient really developed a very bad inflammation post-surgery and also rise in IOP, and the patient did not report to us for 2 days, thinking that the vomiting and all is because of something else. And as you can see, it ended up with a dilated fixed pupil, and we had to remove this phakic IOL. It is always a challenge to remove a phakic IOL when the patient is also phakic. And especially when you have to retain your crystalline lens. So here we are trying to create a space because there is a lot of inflammation. This is not something like a phakic IOL which you are going to exchange because of a size problem. As you can see, there is a lot of adhesions. Can you switch off those lights? I'm not sure whether, can you appreciate it good? Okay, fine. So because of this inflammation, this was going to be a difficult surgery. Just taking out the phakic IOL from the sulcus was also so difficult. And like I said, it was a challenge because we did not want to harm the crystalline lens. No, PI was done. PI was done, but probably because of the retained viscoelastic or first, I don't know the reason, but she developed this. And she reported after 2.5 days of the pressure. Not necessarily, because the other eye was already operated by SKP. We operated the other eye, she was fine, and sure, she did not even turn up thinking that this vomiting and all is not related to the phakic IOL. And like I said, this is about 10, 11 years back. But I thought, let me share with you because I was also learning how to explant an phakic IOL at that time. I think I have only 4 minutes, so I'll try and... So this is the most important part, trying to grab the phakic IOL. We have to understand that we might have also made a tunneled incision. So the tunnel also acts as a wall, and it does not allow you to take the phakic IOL very easily. And you keep on, it's very difficult in a phakic patient to try and grab the thin haptic without damaging the crystalline lens. So I tried and tried, and ultimately I succeeded. Once you get a good grip, it's okay. And as you see, the pupil did not constrict at all. So this was one video, and then I have one with cataract. Yes, the pupil, yes, yes. The pupil did not. There's a name to that syndrome which I keep forgetting. Yes. No, it in yeah. In fact, I'll just the patient came to us in 2.5 days, and we were also not very sure what to do. We tried to constrict and do, like I said, this is about 11 years old video. I was also not that smart at that time. So we waited for another week before we actually thought of implanting, because the patient was minus 11. Other eye was already phakic, I was done. Pachymetry was 460. So we were also trying to debate कि क्या करेंगे, whether this will go away. Nothing, contact lens. Yeah. So this was very obvious, right? The patient developed a cataract. So you see now this technique is very easy. The railroad technique or whatever you call, you keep on grabbing. Hand rowing. Yes. That's why I chose two. The one in which I did not know, the one in which I knew. And then once you remove the phakic oil, it's pretty simple. It's a routine cataract later on. The only thing you need to be very careful is not to constrict the pupil. That's it. I think I'll end my presentation here. Thank you.
See this, removing the phakic IOL, you know what happens when you try to pull it out, it springs back.
Yeah.
And the other difficulty is because the haptics are very thin and it can tear and come with your forceps.
You bite it.
So you need to have the proper forceps, some serrated and wide forceps to hold the lens first properly. And once you pull it out, then you can do a hand over hand technique. And once half of the lens is out, it comes out very easily.
In fact, initially we were always, see, at that time the only player was ICL, and they gave you those forceps, the reverse opening forceps. But I think that was a bad idea. Only our simple MacPherson is the best, which should be good. Sorry? Yeah, that is the best way of doing it. Like we all learn all these things after our rich experience and listening to such talks.
I had done a phakic IOL, that is the antechamber IOL, and patient developed postoperative glaucoma, had Uret-Zavalia syndrome. But she was 6/6. The only problem she had was blur, in the sense like when she went out in sunlight, a lot of glare. And she didn't want to explant it. After 15 years, she developed cataract, and recently, about 4 or 5 years back, I explanted and did an iris encerclage. I did a cataract and did an iris encerclage. So it can happen. Uret-Zavalia syndrome is something which can happen with high intraocular pressure. What happens is it's the atrophy of the iris. So, yeah.
So, so one of the lessons which we learned after this particular patient was, the patient was 120 kgs, she was a short neck, all that stuff, and probably our viscoelastic cleaning was not good. So now what we have started doing is, whenever we are in doubt, we first of all give a mannitol and then let the patient go. Then this has never happened. So that was one tip which I got. Yeah, now PI is, yeah, could be.
I think you must have done a lot of phakic IOLs. You can tell us what is the rate of explantation then and now, and if at all you're explanting, what are the indications? Your name is Tejas, so you can put some light on that.
Okay, so pre-centra flow and post-centra flow, is that what you want to actually?
Yeah, also the time is not necessarily central flow, it's also the maybe 10 years ago and now. How many are you explanting now and for what?
I would say in the last 5 years we have explanted none, and whatever we explanted was
very
before
gratifying.
That. Yes. But we are very strict in our regimen and choosing the patients. Any outliers, and we try to dissuade them from a phakic IOL. Somehow we have become more mature, but none in the last 5 years, I would say. And like the patient of cataract, he developed this cataract after 9 years. So and this also was not a central flow, if you saw. So the cataracts, the most important reason for explantation was a cataract, and one of that Uret-Zavalia syndrome. Otherwise, we have been very happy with our sizing also, and twice we did not actually explant, but we reoriented the phakic IOL to make it more suitable inside the eye.
How many developed cataract? Forget about glaucoma.
In this 12 years, I would say 11 of them have developed cataract, and we have removed those cataracts.
actually.
And
was
the
ascribed to
least,
the
the
phakic IOL, not as a natural development.
no, no, no. I believe that was because of because these were all in their 40s now,
myopes,
less than 40.
See,
Yeah.
these are all high myopes and they have a tendency to develop early
Uh,
cataracts. So per se, because of phakic IOL, if it happens within 5 years, then you can say it's because of phakic IOL.
Also
I
the
am not-
location, it's more
Exactly.
anti-cortical.
So, if it's posterior, then it's definitely not because of that. Even we have a very, very low incidence of cataract post
Yes.
phakic IOL, and explantation rates are very, very low.
I think thanks to the imaging techniques and our insight has also probably become broader. Now we know exactly which are the outliers and the selection criteria, and maybe the initial enthusiasm died down in the wake of the wisdom
Absolutely.
of all the complications coming
Absolutely.
up.
And especially now the only bugbear is going to be a plateau iris, where the iris configuration is not actually what it is seen on a slit lamp. In such a patient, whatever your sizing may be, these patients tend to develop. Because I saw a friend's patient, both eyes implanted and UBM was done, and then we found out it was the plateau iris, very peculiar configuration of the iris insertion which led to this. Otherwise, the sizing and everything was good. So there are always some
They have a very
exceptions.
bulky ciliary body, which is
Yes,
actually a plus
exactly,
organ.
yes.
In fact, I handled glaucoma in my hospital, and we used to, well, in the past, like 10 years ago, like occasional patients coming up with all the problems. But I think last 5 years, even I have not seen a patient from a refractive department coming glaucoma problem to me, actually.
So you were trying to double check with me when you asked me that question. Thank you.
Yeah, sir, I think one important point that we got from you in the first case was you said you did not do anything heroic after the patient had a complication. You just counseled the patient and gave an contact lens, which I think is a very, very important
Yeah.
takeaway for all of us who are doing here, that not to get your ego in between and
Yeah.
do what is best for the patient.
And the contact lens fitting in this patient is, the patient was already on a contact lens before the surgery. So it was very easy. In fact, that's the main counseling between a phakic IOL and a LASIK. That this is absolutely a phakic IOL is a reversible procedure. It's very difficult to fit a contact lens on a patient of LASIK.
Thank you so much, Dr. Tejas.